actually, as cardiologist community here in Kuwait, to treat patients aggressively, but that's not necessarily true always. And that's what I told you. I might treat somebody else, you might treat somebody else in a different way. In Kuwait, probably you're not going to get, as a primary prevention, I'm not sure that we're going to get that difference because, again, most of our, you know better than me, in polyclinic, you're going to get our patients when they have their cholesterol. They are not in the gray zone. They're usually 6, 7. So you don't have that issue, big issue. It's usually, it becomes an issue when your cholesterol is in the range of like 2.5 to 3.5. That's where is the discrepancy between the American and the European societies. That's when you have to use other things to help you with your decision making.
Thank you, Dr. Wissam. Thank you. We'll give you this.
Lazim?
Yeah. This عشان الصورة بس. So the second talk will be given by myself. Today I'm going to talk to you about triglycerides and a little bit on the HDL. We're not going to go very deep because of the time, but we always talk about an LDL and LDL and statins, and let's look at the role of triglycerides in our patients with high risk. This is a case you see probably in your daily practice. Somebody who's a 57-year-old male, known coronary artery disease, BMI of 27, which is not very bad, LDL of about 1.8, triglyceride around 3.4, low HDL. He's very well in terms and generally with his treadmill exercise, treadmill test, statins, blood pressure medications, aspirin. He's always on these. And does this patient require additional treatment? And if so, what we should give him? And this is a very common where we get this slight elevated triglycerides, low HDL. We see it very commonly in our patients. He's on statin, he's happy, and most of the doctor will just pass and say, just reduce your carbohydrates and you will be fine with time. We know that diabetes overall is not anymore just a risk factor for ischemic heart disease. We know it is a risk equivalent. That means when you develop diabetes, when you have this kind of metabolic syndrome, you're actually risk of developing another MI is similar to someone who already developed an MI. And this is, by Hafner, when he changed the idea from this study, the look at the diabetes, from being just a risk factor to risk equivalent. And you can see here that people with prior MI on the left side have similar risk on the right side with people with diabetes and no prior MI on the yellow bar. So they have the same risk of developing diabetes. That's why we know that anybody with diabetes, they have this kind of risk equivalent, and they say diabetes equals the first MI in the life of the patient. And we know that diabetes kills people. So all mortalities, as you can see here from this graph, is going down except diabetic patients. Their mortality is continuously actually leveling or even going up compared to other mortalities. And if you look at decline in coronary artery disease because of availability of drugs and cath and cabbage and early intervention, if you have diabetes and obesity, actually your risk is not decreased. So there is something about this metabolic syndrome that actually make the risk very high in patients with coronary artery disease. And we know that from many epidemiological evidence that diabetics die of heart disease. So this is the first killer of our patients. And if we look at the diabetic dyslipidemia, it's a little bit different than the straightforward familiar hyperlipidemia, where you have, as it's shown by several studies, they have low HDL, high triglycerides. And this is the mainstay abnormality that we see in patients with metabolic syndrome. And this was seen in the Framingham Heart Study, where actually they looked at a big population of people in the Framingham, and they have many, many data looking at several things, and one of them is the lipids and you can see here in red, decreased HDL and increased triglycerides is one of the peculiarity you see in patients with diabetes. The same thing in the UKBDS, the biggest type 2 diabetes trial. Similar finding was there seen where you have high triglyceride and low HDL. Now, if you look at patients who are admitted to the hospital and look at their lipid profiles, and LDL is there, and we know their LDL is high, but most of the time you can see in the left side, their triglyceride is always high. So triglycerides seems to be associated with ischemic heart disease, and we know that high triglyceride is associated with increased risk even if your LDL is low. And this is from the PROVE-IT 22 trial. See if you have high triglyceride on the left side, you can see the risk is higher. So having high triglyceride, even when your LDL is controlled, that means your risk is high. And the reason is because triglycerides make your LDL more small and dense. And small, dense LDL, they are actually bad LDL. They are having decreased clearance. They get into your vessels very quickly. And that's why when you have this metabolic syndrome, these patients, as Dr. Bassam said, they have very high risk of developing ischemic heart disease. Look at the difference between the two and see these two patients down there. These two patients, they have similar LDL and they have different HDL. And you can see the difference between the small dense LDL and the large dense LDL. And many studies, epidemiological evidence showed that if your triglyceride is high, that increases the risk even if your LDL is low. And you can see on the top left there, you can see high triglyceride actually increase the risk of ischemic heart disease and cardiovascular events. Low HDL is an important thing, although until now we don't have many modalities to actually increase our HDL except just lifestyle modification. We don't have specific drugs, but we know that HDL is an important thing. And that actually myself is always when any patient comes to me in the clinic, my eyes goes to the HDL, even before the LDL. The LDL, we know you start statin, as Dr. Bassam said, but the HDL, tell me how risky is this patient. So if this patient have low HDL, and you can see here from epidemiological studies that the lower your HDL, the higher your risk of ischemic heart disease. And that goes the same, as we said, with the triglyceride. Look at these two patients. They have, one of them is LDL of 100, and the second one have an LDL of 200. And you expect that the patient with an LDL of 200 having a higher risk compared to the one with a 100. But they have the similar risk because the guy with the 100 have low HDL. So even if your LDL is low, if my patient LDL is low and his HDL is low, that means his risk is not very low. So we have to think about our HDL. We know, again, this is from the TNT study, the quartiles of HDL, the lower your HDL, the higher your risk, even if your LDL is low. So next time, let your eyes go to the HDL and look at it very carefully. This is, again, early and late mortality post-events, and you can see if you have a low HDL, that's in the blue, your risk is higher, even early or late at the events of cardiovascular disease. So it goes throughout the duration of the disease, early or late. If you have a low HDL, it will cause. So we know if you have increase in 1% of your HDL, there is around decrease in 3% on the cardiovascular risk. Compared to LDL and compared to triglyceride, you can see that HDL is more effective. Unfortunately, we don't have a drug yet to use it. So when you are treating patients with statins and we lower their risk of developing ischemic heart disease, the question comes, is there any more risk that we can actually help? And that's what you call the residual risk. And the residual risk is clear from all these big trials from the statins. Many events happening. You can see, most of the big trials, there is reduction, significant reduction in ischemic heart disease. But look, from 28 to 19, what about the rest of this? What about the rest of the 19? They're still developing, ischemic heart disease. All this reduction goes between, 30 and 50%, but what about the rest of the 50% who did have events? So people still having events even when their LDL is lowered. And this is proven by several trials, several anti-lipid trials, and you can see here again, lowering cardiovascular risk with statin doesn't mean that your risk is zero. Again, this is using Jupiter study using a very potent statin, as Dr. Bassam Urbanat said, like rosuvastatin. There is around 44% reduction in risk, but what about the rest who developed MI? This is telling you that there is still risk of developing MI even if you have a big trial. Again, lots of meta-analysis looking at if you have a lower LDL, doesn't mean that you don't have more risk to develop. Although your risk drops, but still the risk is there when you have low HDL and high triglycerides. This is aggressive LDL lowering with maximum dose of statins. And looking at the residual risk, and you can see here, if you're actually, look at this, is 10 and 80 milligram, still, if you go to 80 milligram, you still have 8.7 risk still there lingering, and these patients probably because of their HDL. Again, with the HDL level, if your HDL level is low, your risk benefit is actually low too. So this is just to show you the importance of an HDL and a triglyceride when you look at the lipid management. Although, for example, for the HDL, we cannot do anything, but actually that will make yourself looking at this patient with higher risk. So you can do other things like controlling triglyceride, controlling blood pressure, tightening the diabetes, because you tell your patient that you are at a higher risk of developing ischemic heart disease. And in our population, I don't remember finding somebody Kuwaiti whose HDL is 1.2 and above. Very rarely. They're always having low HDL, and this gives you the risk. And this is the big trials of statin, and you can see if you have a less HDL, your risk is still higher. Now, for drugs to raise HDL, as we said, we have no much medications. There's no evident proof drug to use, so we don't encourage to put patients on drugs just to raise HDL because we don't have an evidence. But these are the drugs that actually have the most effective effect on HDL and triglycerides. So in summary, despite achievement of LDL goals, patients remain exposed to higher residual risk. High triglyceride and low HDL levels are strong predictors of cardiovascular events, and statin therapy incompletely address vascular risk attributed to elevated triglyceride and low HDL. So this is just to summarize the effect of these two, HDL and triglycerides. Now, when you talk about triglycerides, fibrates is one of the drugs we use to lower our triglycerides, and you have lots of experience. It's available in the Ministry of Health. We use them on our daily basis. Now, fibrates, they have lots of effects. They increase your HDL, they increase your ApoA1, decrease your total cholesterol, the bad cholesterol in red, the total, the VLDL, okay? Increase ApoA2 and decrease triglycerides. So this is the summary of the effect of fibrates. They affect the PPAR alpha, and they have lots of arms of effect in the metabolic status inside the body, with basically raising your ApoA1 and reducing your VLDL, leading to a better moiety of lipids inside the body. So when you look at the small dense LDL, this bad, oxidized, easily oxidized, that goes directly to the vessels, it make it more big and buoyant LDL, which is less penetrating to the vessels. They have lots of peripheral vascular effects on our coagulation, on our vasculature, endothelial dysfunction. They have lots of theoretical and also proven effects on our endothelium, which is a favorable effect. And this just to summarize how fibrates work. So they increase your LDL particle size, they increase your HDL by a modest effect, and they reduce your triglyceride. That's in summary. Okay, there are lots of drugs available. They lower the LDL by around 5 to 20%, HDL by 10 to 35%, and triglyceride by 20 to 50%. Okay. When you combine them with statin, there's always a fear from doctors to combine fibrates with the statin because of side effects, effect on liver, effect on liver function, effect on muscles and CK. And this is a legitimate concern. So when you decide to give a fibrate and statin, you have to watch your patient very closely. So when you put them together, they actually have a favorable combination. If you look at this table, you can see the effect on LDL and triglyceride and HDL and postprandial lipemic effect of the fibrates. They all complement the statin. So when you have a statin fibrate combination, usually that's a very favorable combination given the right patient to use, which is patients with high triglyceride in general. This is just the Canadian guideline, and that's what they said about the combination therapy with fenofibrate and bezafibrate plus a statin appears to be relatively safe. And they particularly said these two because there are evidence for these two drugs available in the literature where you can combine with a safety issue. So I certainly do combine fibrates if my patient's triglycerides, persistently high despite lifestyle modification and good LDL control. And you have to be safe when you use them together. So, reducing the cardiovascular risk in general with dyslipidemia, I put them in ranking. So the established evidence we have is lowering LDL. So don't jump from today and just give fibrates to everybody. LDL is number one. And statin is going to be number one drug we use for our patients. Reasonable evidence affecting the triglycerides and HDL, and there is some reasonable evidence, although we don't have a randomized big trials to show a long-term effect, but we use them in patients, certain patients, especially when their LDL is well controlled, they still have high triglyceride, low HDL, despite lifestyle. So then this is the good patient to use the fibrates as a combination therapy. And there are lots of other modalities of dyslipidemia beyond the scope of this lecture, but also lots of things about it in the research. Let's go back about my patient. So this is a patient who comes to our clinic. He could pass and go away with just keeping on statin. His LDL is very low. And so what does happen to him? This patient have a sudden MI and collapse, and he died because of acute MI. So does low HDL actually was part of his story? Probably is. So when you have somebody with persistent hypertriglyceridemia, don't leave this patient. Try to modify their LDL triglyceride by lifestyle. If it did not work, then you think about fibrate as an option. So in conclusion, residual cardiovascular risk remains a problem despite statin-mediated LDL reduction. Low HDL is an independent factor for coronary heart disease, and I encourage you from now and then just to have your eyes look at the HDL all the time, because that tells you is your patient is a very high risk or not. Most clinical trials and observational data suggest that raising HDL may reduce cardiovascular risk. Triglyceride plays an important role in the metabolic status of the patient, and fibrate statin combination is safe despite you follow up and choose the proper patient. Thank you very much. So any questions? We have 2 questions, please. I think because of the sake of time and Salat al-Jum'ah, we will continue without the break, and then we'll just take the break and the Jum'ah prayer, so we save time.
Thank you for this presentation. Do you think that all fibrates are the same in safety to use with, in combination with statin? Yani Libantil and Lopid the same in safety?
Yes. In terms of combination therapy, according to the guidelines, the Canadian guidelines, I put them because they said it clearly that these 2 drugs are the safest based on the evidence. We don't encourage combining gemfibrozole, for example, the statins, because there is evidence that actually it have more complications. So if you have somebody with a statin, you'll probably go for fenofibrate, bezafibrate will be the best combination available for your patient. Dr. Zaidan?
Thank you, Dr. Walid. I think, or I guess this dyslipidemia is secondary, not primary, maybe due to diabetes or something else. So what about the patient, or not patient, normal people? They have no problem, not overweight, non-smoker, nothing at all, but they have high triglycerides, high LDL, and low HDL. Do you advise to start whatever drugs we are now discussing, yes, or not?
Yeah. When you talk about primary prevention, now, primary prevention, I look at them, either they have FH, which is a clearly different than familial combined hypertriglyceridemia, which is the one you alluded to. High triglyceride, high LDL, and low HDL. And we see that a lot in patients, 25-year-old and 30-year-old. These patients, there is no evidence that treating them very, very early that actually going to prevent heart disease. So primary prevention should be very carefully looked at. The most important thing is to calculate the risk of the patient. And I divide their triglyceride into 2 categories. Category which is related to cardiovascular long-term, and category related to pancreatitis. So if the patient have high triglyceride, more than 10, that's pancreatitis stuff, and that's where you start your fibrate very early. But if patient have triglyceride less than 10, probably lifestyle, you may think of fibrates in this patient. Look at his thyroid, his hypothyroidism is a very common cause of hypertriglyceridemia. Type of food he eats, and also alcohol, which is also very common that people they drink. So long-term primary prevention, we don't have evidence. So that's the bottom of the line. Yeah. Thank you very much.
Doctor,
well,
I have
yeah,
one question.
في سؤال?
Yes.
Yeah,
in diabetic patient, when you will start the fibrates, what level for the triglyceride?
So if I have a diabetic patient, his LDL is controlled, I use a statin.
Yes.
That's your #1 drug for these patients. I try to avoid fibrates until my patient's triglycerides are persistently high despite efforts of change of lifestyle. If his HbA1c is controlled, if his HbA1c is high, I would not start fibrate. I will give him time to actually lower his HbA1c at least to below 8, and there's the effect of the postprandial hyperglycemia and increase in free fatty acid will be reduced. So HbA1c control, if that's okay, his LDL is okay, he still have low HDL, high triglyceride, then I would. Now, the definition of high triglyceride, it's going to be above 2. Basically, above 2, his risk factor is going to be high. But if you have a good HDL, then you can, HDL more than 1.2, I would probably delay fibrate at that time and give him time with his lifestyle. Okay. Thank you very much. We'll go to the next speaker. So our next speaker, Dr. Ajan, he's Associate Professor and Consultant of Endocrine and Diabetes from University of Leeds, PhD from University of Sheffield. Dr. Ajan received award from National Institute of Health because of contribution to all kinds of research from basic, translational, and clinical research. okay? He have interest in hypoglycemia and continuous glucose monitoring. Now, today we're going to talk about a new concept in continuous glucose monitoring, and he's going to talk to us about what we call AGB, and also later we have a full workshop to talk about how to look at patient continuous glucose. We used to look for glucometer and numbers, but now science is changing, and also looking at the patient glucose all over the day is very important. Dr. Yan, thank you very much.
Thank you very much. Good morning, everybody, and thank you for that kind introduction. I must confess, I arrived today at 7 in the morning and had 2 hours of sleep, and I was very worried that I'll be sleepy, but coming to this stunning place that woke me up immediately. So it's absolutely great here. I'm going to talk to you about new ways of glucose monitoring, and I'm going to tell you a little bit about glycemia, what I think, because personally I think glycemia is the most difficult risk factor to treat in people with diabetes. This is my disclosure slide, so moving on swiftly. We know that we treat glycemia and diabetes to prevent complications, and in the UK, diabetes was the main cause of blindness until recently. Things have changed, so we're doing much better there. Diabetes remains the leading cause of renal disease, of end-stage renal disease, and as the two previous speakers pointed out, diabetes is a very high risk factor for cardiovascular disease. Now, what we try to do in diabetes, we try to prevent the complications, because once the complications are there, they're very difficult to reverse. And there's a very good correlation between HbA1c and complications. So if you have a higher HbA1c, your risk of microvascular disease increases. What I mean by that, retinopathy, nephropathy, and neuropathy. And also your risk of macrovascular disease, i.e. coronary artery disease and stroke, also increases. Now, of course, the question is, there's this really great association, but does it necessarily mean that if we reduce glucose, we prevent complications? And I'm going to take you back to the DCCT trial for that. This was published more than 2 decades ago. And the reason I'm taking you back to the DCCT is because that was done in people with type 1 diabetes. And if you want to look at the effect of glycemia, it's always better to look at type 1 diabetes. And they ask a very simple question: if we get tight glycemic control, do we do better than conventional treatment? And you can see the conventional group had an HbA1c of 9%, the tight glycemic group had an HbA1c of 7%, or 53 millimole per mole, which even by today's standards is not too bad. And what they've shown very early on, that you get less retinopathy in the intensively treated patients, and as you can see, the lines are separating after 3 years, so relatively quickly the lines start to separate. They also looked at reduction in macrovascular complications, but there was no difference between the two groups. Not particularly surprising, because this was a young group of patients. They did not have that many events. But there was something very interesting about the DCCT. What they've done, so the original study lasted for 9 years. You can see the HbA1c in the two groups was different. Then they continued follow-up of these patients. After 9 years, you can see the HbA1c in the two groups was very similar. So they continued the follow-up for 17 years. And what happened here was very interesting. There was a clear-cut difference in cardiovascular events in the intensive versus the standard arm. So there was a reduction, 57% reduction in cardiovascular events. And this is despite the fact that after 9-10 years, the HbA1c in the two groups was similar. So that tells you, A, that improving glycemic control indeed reduces macrovascular complications. The second thing it tells you, that you need to start that quite early to see an effect. And the third thing is that to see an effect, you need many, many years. And that is important clinically, because If you have a newly diagnosed diabetes patient who's 40 or 45, you need to get that glycemia under control as quickly as possible. If you have a patient who's 85, 90, glycemia becomes less of an issue in terms of importance. I'm not saying get the HbA1c to 15%, but you can relax the targets a little bit. So it has got practical implications. Then comes the however. And however in English, to me, is a very powerful word. You always sort of feel a little bit nervous when people say however. And actually, there's a very big however. And the however is the ACCORD study. So the ACCORD study was conducted in people with type 2 diabetes. And the study asked the question, if we improve glycemic control in these type 2 diabetes patients, do we reduce cardiovascular events? Their HbA1c target was very tight. They wanted to get an HbA1c of 6%. They did not get a 6%, but they still got a 6.5% in the intensive arm. The primary outcome was non-fatal MI, stroke, or cardiovascular death. As you can see, in the intensive arm, there was a slight reduction in the primary endpoint, which was not significant. But what was really scary, that in the intensive arm, if you look at the right hand of the slide, there was a 22% increase in mortality, which was significant. And then people started thinking, ooh, so if I get tight glycemic control, I'm killing my patients. So that was very interesting and very scary indeed. Nobody knew exactly why in the intensive arm people were getting more death. Then came ADVANCE. ADVANCE was a similar study. Again, it conducted on type 2 diabetes patients. Up to a third of patients had established cardiovascular disease. And they wanted to look at intensive glycemic control versus standard therapy. Again, they reached 6.5% in the intensive arm. There was no difference in the primary outcome. So intensive standard arm, no difference in reduction, cardiovascular reduction. When it comes to death from any cause, there was no increase in mortality. So unlike ACCORD, ADVANCE did not show an increase in mortality. And some people who are sort of the optimists would say, oh, the lines are separating in favor of intensive arm. We don't know. The bottom line is there was no difference. And of course, the big question that emerges, why was there a difference between the two studies in terms of mortality? One thing that was put forward is the speed of reduction in HbA1c. If you look on the right, you can see ACCORD reached an HbA1c reduction to 6.5 in 6 months. Very, very quick. The study was run by the Americans who tend to be quite aggressive in the treatment. ADVANCE was run by the British. And in Britain, we like to do things slowly. We like to have a cup of tea, think about it. It took 3 years to reach target. So half a year versus 3 years. And that inevitably resulted in far more hypoglycemia in the intensive arm of ACCORD. So in the intensive arm of ACCORD, you had 10.5% hypoglycemia versus 3.5% in the standard arm. In ADVANCE, 2.7% in the intensive arm. Now, there has been a lot of analysis to see whether hypoglycemia was the reason for the mortality, and no one can agree. But one thing for sure, that in both arms of the study, intensive and standard, hypoglycemia was associated with increased mortality. So I think our obsession with HbA1c reduction has to be tempered a little bit by thinking about hypoglycemia. And I'll talk about that a bit more. So this is the same data presented differently. You can see this is the ACCORD study. You see the standard arm had far less hypoglycemia compared with the intensive arm at different time points of the study. Again, I said we do get obsessed with HbA1c, and to me, lower is not always better. This is an observational study that looked at the relationship between HbA1c and mortality. Very simple question. I personally love observational studies when you want to talk about safety. They are very, very good. Look at the numbers. 28,000 patients who are not on insulin. And you can see the relationship is not linear. You get this U-shaped curve. So if you have an HbA1c of 10%, your mortality is the same as an HbA1c of 6%. And you have that safe HbA1c of 7 to 8%. If you're on insulin, there were 20,000 patients on insulin, that safe window is narrower, is between 7.5 to 8%. Now, the study has been criticized because people said, well, yes, but at the low HbA1c range, you had people with renal failure, you had all sorts of other comorbidities. And I completely agree, that is correct, but it makes you think that actually lower is not always better. I'm not saying don't lower HbA1c, but make sure that you lower it safely. Now, these are data from Leeds, where I work. We looked at ambulance call-out for hypoglycemia. So we're talking about very severe hypoglycemia in the community where the ambulance services were called out. And we've got now more than 10 years data. I'm just going to show you a couple of years data. Around 60% were type 1 diabetes patients, and roughly 40% were type